Who are the patients, maybe Dr. Ma, you can comment on this, who are the patients that may be a little bit higher risk or maybe a higher risk category among patients who are receiving Ibrutinib monotherapy? Are there data that indicates there are a particular patient population that we need to monitor more closely?
Right, so I think probably the most information I got was from the relapse Ibrutinib trial, by analyzing patients, relapse refractory patients who were treated with Ibrutinib alone. That's from the RESONATE study. So based on subgroup analysis, the progression-free survival overall was 52 months, median progression-free survival for all patients. But if you look at 17p deletion patients, those patients, the median progression-free survival was only 26 months. So that's one high-risk category. The other high-risk category is the patients with complex karyotype. So those patients, the median PFS was 33 months. So those were significantly lower compared to the rest of the patients. The rest of the patients, actually, the median progression-free survival for the low-risk patient have not been yet reached. So there's definitely a big difference.
And I think one important point is that in the data that Steve was quoting in the frontline setting, we've seen very few patients with 17p treated. So in the original study, I believe there was one patient, and in the RESONATE 2 study, that actually excluded patients with deletion 17p.
That's
so
right.
So we don't know as much. We have one study from the NIH that looked at the upfront setting for 17p patients with Ibrutinib, which looked promising. But I think that's an area where we need more data.
Yeah, it's interesting. Some of our colleagues are already advocating for those patients right off the bat, combination therapy. Of course, we can't do that from a practical standpoint, but I think that's an area that definitely needs to be looked at.
Nicole, can you comment on how you manage atrial fibrillation and?
Oh, I want to talk more about 17p. No.
Go ahead. Sure, go ahead.
I think the one point to make is that even though it's been a game changer, and I think everybody needs to take that, is you need to, if you have a 17p deleted patient, you need to start them on a novel therapy. So yes, I think that's one thing that we can all agree with and we should promote, but those curves, absolutely, the PFS for those patients are shorter. So we have to think that just because you're starting them, let's say on Ibrutinib, that's not the end. Right. Particularly if they're younger. So you actually have to plan ahead and think, okay, this is great for now, but, what about, transplant, venetoclax, CAR, there's so many other things, because they will relapse. It's just better than chemoimmunotherapy when, median life expectancy of patients who failed a purine analog with a 17p was 9 to 12 months. So it's just very different, but it's, by no means are we done with our 17p deleted patients. Okay, sorry. Let's go on.
Just briefly, atrial fibrillation and management of anticoagulation. And
yeah, I think this is probably the question we all get asked the most. Do you stop a patient if they develop atrial fibrillation on Ibrutinib? And I think it does vary. And it varies by patient too, and patient preference. I think if somebody is asymptomatic, develops atrial fibrillation, that's something that's still potentially manageable, then you don't need to necessarily stop the Ibrutinib. However, there are some of our patients who develop profound symptoms, congestive heart failure, poor ejection fractions, and those need to be managed. And so I usually hold the Ibrutinib and manage their cardiac issues and get them through that. It also depends on which line of therapy we're also talking about, right? So for patients who are multiply relapsed, and Ibrutinib was a great drug, they will stay on therapy because they realize that their potential options of, depending upon what they may or may have not received, are more limited, and so you're co-managing their side effects with concomitant therapy with Ibrutinib. So it really depends on how, I think that certainly I have patients who have AFib who are still on Ibrutinib and doing well, and then I have other patients who, it was their first line in therapy and they were like, absolutely not, I don't want to have to be on anticoagulation and cardiac meds for the rest of my life, and please choose an alternative agent. So I think that it depends on the options and how symptomatic the patient may be, and so your discussions may be different depending upon the patient.
So it's a great option for patients with 17p deletion. Maybe briefly you can comment, Matt, on, we used to think of 11qs as a high-risk group. Do we still? Do we need to check for 11q? Is it something we should pay attention to?
Yeah, so the data are a bit mixed now, so I think it's gotten more confusing, if anything. So, we originally thought 11q was a marker of good response to FCR, so we were arguing that those patients should get FCR. Then we saw the data from the 1102 study with Ibrutinib monotherapy suggesting those patients had an inferior progression-free survival on Ibrutinib. But now we've seen some larger pooled data sets from Tom Kipps and colleagues suggesting that actually perhaps patients are doing slightly better with deletion 11q on Ibrutinib. So it's a little bit all over the place. I think it is important to check still, but I think it's become more of a research question now.
Mutation status in Ibrutinib therapy?
So I think this is a really important point. So we've had so many different chemoimmunotherapy-based regimens over the years. Every single one has shown an inferior progression-free and overall survival based on IGHV mutation status. And the Ibrutinib data at 5 years suggests that there's an equivalent progression-free survival based on mutated versus unmutated IGHV. That's the first time we've seen that with a therapy in CLL. There's some earlier data with idelalisib suggesting the same thing, and with venetoclax as well. So it does seem like the novel agents are potentially able to overcome the negative prognostic factor.
And Shuo, maybe you can comment on metaphase karyotyping. It's not a test that we've done routinely in CLL. Historically, it's useful in other leukemias. Is there utility for metaphase karyotyping, and is it a special test that we might be able to do in CLL?
So in recent years, there's the concept of complex cytogenetics or complex karyotyping. So that's really referring to a patient who has 3 or more unrelated chromosomal abnormalities using stimulated karyotyping technology. And we have seen that those patients really are very high-risk patients that seem to have overall poor overall survival, but also is very important prognostic factor when looking at different treatments. So far, I think across all different type of treatment, the patient with the complex karyotyping seem to have a poorer prognosis or response or duration of response compared to other patients. So I think that's probably going to become one of the things we should do more as a standard of care,
Well,
even though it's not
depends.
widely available yet.
I think it's hard to recommend that as a routine test to do. If you're going to get the information, of course, you want to do it from the blood, and getting metaphase karyotype from the blood is difficult. So we do the stimulate the culture, not readily available to a lot of people. But I think that as we start looking at, say, our younger patients, even patients on our novel agents, you're looking at the broad picture, how are we going to manage them for many, many, many years? That might be where you want to get that information. So, for example, they can decide at some point whether to take the risk of a more significant therapy, transplant, CAR T-cell therapy. You know, if you have somebody certainly with 17p and a complex karyotype, as good as our novel agents are, it's not going to be good enough. And that's somebody that might be enough to say, okay, let's enter this clinical trial for CAR T cells or something.